It's 12:30. Thank you for coming today's journal club. My name is Keel, and this is Dr. Ellika Rasooly, and also special thanks to Dr. Jaimes for assistance in this presentation. We have no relevant disclosures to announce today. Our objectives for today is we want to practice formulating a specific clinical question and then understand the design that would best answer the question that we propose. We'll use the PICO-TT format. Then we're going to appraise the evidence that's available from the articles that we find for two different interventions using the CAT format for a randomized controlled trial. We'll then compare that to an article that we found, which was a cross-sectional study. We'll review concepts that include block randomization and discuss Cohen's D analysis. We'll also want to distinguish the important factors for the determination of internal validity of our studies, and then talk about the external validity and its ability to be used in clinical practice. So what do we know? We know that UTIs are common. They occur in about 5 to 7% of febrile children under the age of 2. Obtaining urine under this age group in precontinent children for urine analysis can be quite tricky, quite demanding, and quite invasive. We wanted to find a method to obtain urine that's reliable, fast, free from contamination, and the least invasive possible. So urination in infants is spontaneous, it's small, it's frequent. We think about them having a wet diaper after maybe every single feed. As the child grows and gets older, they start to gain more control, and this is reduced to about 4 to 7 per day. The bladder is controlled by two sacral nerves, the pudendal and the sacral nerve, and they're not under your control until about 2 or if not older. So we wanted to propose a clinical question to answer, can we find a better way to collect urine? So we used the PICO format to find the population of precontinent children. Our intervention was going to be some type of bladder stimulation technique to promote urination. We wanted to compare it against no intervention at all. Our outcomes we wanted to measure was, did they urinate? And so the type of question that we're looking for using this format is an intervention study. We wanted to try to find an article that was a randomized controlled trial or a systemic review. So what did we find when we did our search to answer our PICO question? We found two techniques under review for collection of midstream urine catheterization. One method was the quick-wee method, and the second method was bladder stimulation technique. These methods were not what we wanted to find and answer all of our questions, but they were the best two methods that we could find for our proposed hypothesis. So the bladder, next slide. Of these two methods, the quick-wee method is a randomized controlled trial. So pretty high up on our scientific evidence hierarchy pyramid, while the next study, the bladder stimulation technique, was a cross-sectional study. So a little bit lower down on our triangle here, but the best we could find for our studies. Next, Dr. Rasooly would like to talk about the study that she will analyze, and then I will talk about the next study.
Okay. So the first study we looked at is, the title of the study is called Faster Clean Tech Urine Collection, or the Quick-Wee Method from Infants. I don't know if you guys have trouble hearing me. I'm 6 years old, so usually. It's a randomized control trial, as Dr. Keel mentioned. It's the authors, the primary author is Jonathan Kaufman et al. Was published in the British Medical Journal in 2017. So the study design is a randomized, prospective, non-blinded superiority trial and looked at two arms of the study, standard clean catch versus the quick wee method, which I will go into further detail later. It took place over a 6 to 7 month period between September of 2015 and April of 2016. It was done in Australia in a pediatric emergency department in the Royal Children's Hospital in Melbourne. There's a quick video, it's about 48 seconds long, depicting the quick wee method that is worthwhile to take a look at. Ending the,
Yeah, these.
Good way is a quick and simple way of collecting your sample for very young children or contextualize science. And this is important because urine gas infection will utilize a common stage group, but collection sample to check things size can be difficult and very time consuming. And so with this degree method, clean around the urogenital system, then we use cold fluid to soak excessive fluid, and we rub the lower part of the abdomen circular motion to trigger those bladder reflexes and have a cup ready to capture urine samples when they pass urine. In our trial, one in 3 children had a sample collected within 5 minutes.
I'll talk about the two arms in a second. So the inclusion criteria, it included infants aged 1 month to 12 months of age, and they were also corrected for prematurity if they were less than 36 weeks, and also those babies that required a urine sample, and I'll talk about the breakdown of those who did require a urine sample. They excluded those, of course, less than 1 month of age and greater than 12 months of age. They excluded the ones less than 1 month of age because of the risk of serious bacterial infections. And they also excluded infants with anatomical and neurologic abnormalities affecting voiding or sensations, like, for example, a baby with spina bifida. Also, they excluded a baby that had numbing cream placed in the suprapubic area for suprapubic aspiration. Intervention, so for both arms, the usual care arm and also the quick wee method, they prepare the child for a clean catch, they lay them on the bed. They then open this opaque randomization envelope, which would tell them whether the baby would be randomized to either the standard care arm or the intervention arm, and then they would remove the diaper and they would start the timer for the 5 minutes. Either the parent, caregiver, or clinician was ready with the urinalysis cup to catch the urine. The genital orifice was cleansed for 10 seconds with sterile water, and that's the standard of practice over there, just clear with sterile water. So at this time, the arms would be different. So the usual care arm, the clinician then waited for up to 5 minutes for the baby to void spontaneously. The timer would stop at any time up to 5 minutes once the baby would void. For the intervention arm is what we saw in the video. Forceps with a gauze gauze pad would be dipped in cool saline. That was about 37. Cool saline water, that was about 37 degrees, and would be rubbed in the suprapubic area in a circular fashion for, again, up to 5 minutes. But if the baby voided before the 5 minutes, the timer would be stopped at that time.
I'm assuming that's 37
Fahrenheit.
Fahrenheit. So this is cold water, not
It's
37.
cool. It's cool. Yeah, it's 2.8 degrees Celsius.
Okay.
Yeah,
okay.
It's cool water.
It's the rationale for that. As a father, whenever I put my baby in the bathtub and it's warm, you always heat it and come the opposite. What are you doing?
They did the pilot, yeah. I don't know if they had a rationale rationale for it being cold, but it could, I mean, we could do further studies trying warm water too to see
Every time they jump in the cold swimming pool, they're
to see if
the same.
helps. So, also of note, so the children that were randomized and voided during that 10-second cleaning period were also included in the intention to treat analysis. Okay. So the participant characteristics. So looking at both the quick wee and the standard clean catch, they looked at gender, mean age in months, previous UTI, antibiotics in the past 24 hours. And for gender, the quick wee had a slightly greater percentage in males compared to the standard clean catch, 55% compared to 45%. But otherwise, the mean age in months was equal at 5.4 months for both the arms. Previous UTI, fairly equal, 6% versus 9%, and then antibiotics, fairly equal as well. Comorbidities that the patients had: minor renal anomalies, congenital cardiac disease, seizure disorder, genetic syndrome, gastroesophageal reflux. And again, fairly equal between the two arms. Indication for getting a urine sample, as I mentioned before, what patients required a urine sample. So if they had a fever of unknown origin, unsettled baby, which is likely a fussy baby, poor feeding, a suspected UTI, vomiting, failure to thrive, metabolic, electrolyte, or jaundice, hematuria. Again, if you look fairly equal, a slightly greater fever of unknown origin in the quick wee, but fairly equal between the two arms. Very important that they looked at hydration status, because it can be harder to collect urine by a clean catch. So they looked at mild, moderate, normal, mild, moderate, and severe hydration status. The primary and secondary endpoints. Their primary endpoint is they look at voiding within 5-minute period. Secondary endpoint, they looked at successful collection of a urine sample, contamination rate, and also parental and clinician satisfaction with the method. So looking at our results. So this is a table looking at primary, secondary, and outcomes. So their primary outcome was voiding within 5 minutes. So the quick wee method, 54 out of 174 infants voided, or 31% of the infants voided within the within 5-minute period, with a 95% confidence interval of 24 to 39%, versus the standard clean catch was 20 out of 170 infants, or 12%, with a 95% confidence interval of 7 to 18%, and then a difference of proportions of 19%. And this is significant because the p-value is less than 0.05. We're looking at secondary outcomes. The baby voided, and was the catch successful? Did they actually collect urine in the urinalysis cup? So 54 out of 174 infants, it was successful. So 2 babies, they missed catching the urine. So 30% with a 95% confidence interval of 23 to 37, versus the standard clean catch, 15 over 170, so they missed 5 babies here, with a which is 9%, with a 95% confidence interval of 5 to 14, and difference of proportions of 21. And this, again, is significant as well. Contamination rate, so 12 out of 44 infants, and which is 27%, 15 to 43 confidence interval, and that's a high contamination rate. Versus standard clean catch, 5 out of 11, which is 46% high contamination rate as well. So looking here, the p-value is not 3-point Likert scale. 2 means they were satisfied. The quick wee, so they were satisfied versus the standard clean catch, they were neutral. And this is significant, statistically significant. So we're going to move on to bladder stimulation article by Rasooly.
Thank you, Dr. Rasooly. Excellent job there. The second article that we wanted to look into was the evaluation of bladder stimulation techniques to collect midstream urine in infants in an emergency pediatric department by Anthony Tran et al. It was published in 2016 by a large scientific community journal in France, which is PLOS, the Public Library of Science, and was done in Nice, by the way. The study design, we did a cross-sectional study, which is otherwise known as a cross-sectional analysis or prevalence study, which is really focusing on a moment in time that is specific. Our study included 142 infants. It was done over a 3-month period from September to November in 2014, and it took place in the emergency department at the Children's Hospital of Nice. The design of the study was based on bladder stimulation and lumbar stimulation maneuvers. It was performed by 4 trained physicians who each got a max of 2 attempts to be successful. The success rate was the time to obtain urine sample within 3 minutes, and this was evaluated. And discomfort was also measured using the Invendal scoring. And discomfort was stated as anything 4 and greater, equal to or greater than 4. This is a validated tool used for measuring pain and discomfort in children under the age of 8 years of age. It includes 5 categories: facial expression, movement, posture, and interactions with the environment, measured from 0 to 3 for each one of those categories. And they decided in the study that they would have the minimum for discomfort as 4. And at least 1 parent had to consent. So who all was included? All infants under the age of 2 were included at this hospital. Any infant that needed urinalysis was included. And one of 4 trained practitioners had to be present. They had to inform the parents and educate them on what was going to be done. They had to collect their signatures and then perform the technique. The exclusion criteria: any derangements in their vital signs. They didn't have parental consent. Any infant who voided in the sterile bag after the first attempt, or infants whom the second attempt could not be carried out. Parent refusal, leaving the emergency room, or worsening of clinical symptoms. So the intervention was a procedure that involved 3 people. They cleansed the genitals with warm water and soap. The nurse would hold the child underneath the arm with the legs dangling, and 1 person would stand ready to catch, and then the provider, who was trained, was performing the maneuvers. Well, not a cookie. There we go. So basically, what is being done here is a nurse, or it could be the mother, but in our scenario, would hold the infant under the arm. Another person would be ready to catch, and for 30 seconds, at a rate of 100 taps per minute, would tap after cleaning for 30 seconds, making little squeak noises. Then after 30 seconds, perivertebral massage. This will be repeated for a total of 30 minutes. 30 seconds. And then we will have successful urination. Well hydrated. 3 minutes. 30 seconds, 30 seconds, 30 seconds, 30 seconds. Then clean bags would be placed on the infant. They would feed it. repeat her or him, and then after 30 minutes, try a second time for the final attempt. I've lost access to my keyboard. So quickly, favorite song? There's quite a few of them, so you don't always have to be saying aloud, but that one seems to work. So the primary outcomes of our study was the success of obtaining urine during this midstream on a first or second attempt. They recorded variables, urine collection and time, the final diagnosis, UTI or not, gender, age, weight, and discomfort. The statistical analysis was logistic regression analysis was used to calculate the odds ratio. All variables were included and adjusted for gender and presence of UTI. If a difference was noted between the two means that was statistically significant, the effect size was calculated through the Cohen's-d analysis. Cohen's-d analysis is interpreted as small effect, which is around d equals 0.2, medium effect, which is d equals 0.5, or was it a large effect with d equals 0.8. So here you can see what is the effect size. The effect size is the mean difference of two different means to get the effect size. And Cohen's-d has quite a large and complicated formula, but can easily be said as the effect size divided by the relevant standard deviation. So here we have three good pictures here showing you the Cohen's-d. If the effect size is small, then the two areas of the means would overlap even more, giving a Cohen's-d roughly around 0.2. If the effect size is large, less of the two standard deviations of the means of the two populations being examined would not overlap as much, giving us a larger effect size. Thank you. So here, with the clinical data of the procedure, we can see that the average age was 4.7 months. The weight was average of 6.2 kilograms. 14% of those studied ended up having a UTI. The success rate was 55.6 of the overall study. Time to collect urine after bladder was 63 seconds, medium of 52. The 25 to 75 percentiles were 10 seconds to 110 seconds. Discomfort was noted in 58% of the children. The first attempt success rate was 42.3%. Time to collect was 61 seconds. Discomfort and the IBDL score was measured at T0, T1, T2, and T3. T0 is before the procedure. T1 is 1 minute into the procedure. T2 is 1 minute after the procedure is done. And T3 is 5 minutes after the procedure is done. So they had an average, remember the total discomfort with max be 15, and 4 would be discomfort, was 6. And this was only measured during the actual procedure itself. So before and after, there was no discomfort obtained. Success rate in the second attempt was a little bit decreased to 23.2%. So here we can see the success rate by age and months in the top graph, and in the bottom panel we have weight. So the success rate of this procedure under 1 month of age was 89% with a good confidence interval. And as you got older, the success rate went down, as well as if you were under 4 kilograms, success rate was around 83%, and going down with age to just over 27% if you were over 10 kilograms. So here the risk factors associated with failure of the procedure were done through odds ratios and adjusted odds ratios. What was clinically insignificant odds ratio went through 1 for both, meaning that it didn't really matter if you were a boy or girl if you were to be successful or if you were to fail. So gender was not significant in our study. Urinary tract infection, you would think, okay, if they have a urinary tract infection, they might have an increased chance of urinating. But even here in urinary tract infection, it was not significant. So it didn't matter if you were a boy or a girl, or if you had urinary tract infection, if you were successful or not. What did matter if you were successful was your age and your weight. The younger you are, the more likely you are to be successful at this procedure versus the older you are. And the odds ratio for age did not cross through 1, making it quite significant. And then when you adjusted for gender and urinary tract infection, the significance went down a little bit. But weight, on the other hand, when compared to, did not cross through either 1 on odds ratio or the adjusted odds ratio for gender or urinary tract infection, meaning weight truly had an effect on the success of this procedure. Discomfort as well was also measured and noted in the percentiles as discussed before. P-values all less than 0.05, making them all clinically significant for the age weight. Cohen's D, as discussed, between the effect size of the success rate and the effect size of the failure rate, when you take the two means of those two, success and failure, and you overlap them on the standard deviation bell curve, Cohen's D for age had medium effect, while for success, while the weight in Cohen's D, when you overlap the success rate for the weight, this had a large effect, truly solidifying weight as a prominent factor.
Okay. All right, so now we're going to appraise the two articles side by side. Here we have a lot of pictures of little statues. So we're going to start with the internal validity. So the first question is, was the assignment of patients to treatments randomized? For the quickly, yes, and they use randomization blocks. We're going to quickly talk about block randomization. So it's when investigators divide the subjects in our case patients into subgroups, and this is just an example. It's not how our it's not how our investigators divided them. So they divide them in subgroups called blocks, and so that the variability within each block is less than the variability between the blocks. Subjects or patients within each block are randomly assigned to an intervention. So A in this case would be the standard clean catch, and B would be the quick leave method. They use this type of randomization to reduce variability and also confounding and also predictability. So it's not predictable what patient is going to come next. In our article, an independent statistician prepared the randomization schedule, and they had at least 3 different block sizes. So in this example, they're all the same block size. And then they gave opaque envelopes concealing the allocation to the emergency department. So that's what I was explaining before when for both arms they had a concealed envelope, and as they knew the patients were coming in, they would open it bedside. So it wasn't blinded, but it was randomized. And for going back, sorry, this is a new question. For the STIM, for the bladder STIM, it was not randomized because that article was an observational study. So the next question is, were the groups similar at the start of the trial? And for the quickly, it's sort of. If we look back at the participant characteristics, they were very similar between the two arms. They had differences, but the article didn't disclose or didn't report the p-values, so we don't know about the significance between the similarities. So we can't say if they were similar, if they were statistically, if they were similar, because there were no p-values reported. And then for the bladder.
And so were mine similar at the start of the trial? Well, there really was no comparison. All children were included if they met the inclusion criteria as discussed. And were the participant characteristics of my study? Well, there was no real further history that was recorded besides weight, sex, age, and UTI. So there's no other real demographics to kind of analyze. But the kind of conclusion really was gender and urinary tract infections does not affect if a child is going to succeed in this urination midstream collection, but age and weight were, and then as stated earlier, the p-values were significant for results of the procedure, the urine analysis in French there, and the multivariate analysis, as well as discomfort.
Okay, aside from the allocated treatment, were groups treated equally? For the quickly, we don't know, maybe. So looking back, I talked about under secondary outcomes, voided and successful catch. So there was a difference of 2 infants in the quickly arm that they didn't catch the urine versus the standard clean catch arm, it was 5 infants that they didn't catch the urine. So does the quickly method mean that missed voids are less likely? Probably not. It's because that since the study wasn't blinded, the clinician or the nurse, whoever is sitting there catching the urine, is paying a lot more attention to the quickly arm, so they're more likely to catch the urine versus the standard clean catch. They're just doing what they normally do and waiting and catching the urine as they normally do, so they're not paying as close attention. Also looking at contamination, we have 12 out of 44 versus 5 out of 11. So we wonder why only 11 samples were sent for culture versus 44, even though looking back at the patient characteristics, there were equal number of patients who presented with fever of unknown origin and also suspected UTI. So you'd think that more patients would have a culture taken here. So again, there's likely some bias going on that arm as well. So they weren't treated equally.
So were our groups treated equally as well? For the most part, all the providers were trained using mannequins for the whole week prior to starting the trial, and the provider skills were then didn't really play too much of effect, being that each was trained to perform it in one exact way. Also in the paper, it talked about the success rate of different providers, and at the end it wasn't clinically significant on if that one provider had more of a success rate versus the other. So by having the training, it seems to put them all on an equal playing field.
Okay. Were all patients who entered the trial accounted for? So this is a good chart here. So we have one family who declined consent right from the beginning, so they weren't randomized. And then 3 families who withdrew consent because they wanted collection by a different method. And then we have, looking down here, we have 5 who were aged less than 1 month, and then 4 who were aged less than 12 months, and then 1 had that topical anesthetic that was placed for the suprapubic aspiration, so they treated and randomized, and included in the intention to treat analysis.
So, in my study on the bladder stimulation technique, we started off with 212 eligible infants. There was a few that were not included for either parental refusal or vital sign distress, which left us with 204. And then the ones that they actually statistically analyzed was only 142 because 51 had urinated in the sterile bag between trial 1 and the second attempt, or they might have left the emergency department during that 30 minutes, or there was parental refusal on not to attempt the second try. So if they didn't get a second try, then they weren't included for analysis, statistical analysis. And then our success rates and our second attempt performance were then measured.
Okay, were measures objective? For both, again, sort of. Urine collection is objective, either they urinated or they didn't urinate. But then they used validated tools to account for subjective measurements. So something that is subjective, they made objective. So for the quick wee, they looked at parent and clinician satisfaction, and then for the bladder stim, they looked at discomfort. Were clinicians kept blind to which treatment was being received? For the quick wee, I think I mentioned this sometimes. They were not blinded, but they could have been blinded, so that both the investigator and the statistician could have been blinded. They didn't need to know about which intervention, either the clean catch or the quick wee, and then the stim, they were blinded. What were the results? So I went through this table already. So why do these results matter to us? For the looking at the primary outcome, so 1/3 of patients that had the quick wee method done to them successfully urinated, versus the standard clean catch, 1 out of 10 infants urinated. So it's a difference there. In theory, you need to do the quick wee method in 5 babies to prevent a catheterization, and that's the number needed to treat, essentially. Because I didn't mention this earlier. So if within the 5 minutes, if the baby didn't urinate, then the clinician decided whether to go ahead and continue with the clean catch to sit there with the urinalysis cup, or to cast them or do a suprapubic aspiration.
So how large was our treatment effect on the bladder stim technique? Well, we used Cohen's D analysis to show that there was significant effect, especially on weight, with Cohen's D being large, close to 0.8, and age was a little bit over medium effect. So we were able to truly prove the effect of our study, and it was noted.
Okay, and then how precise was the estimate of the treatment effect? Here we're looking at confidence intervals, and the confidence intervals are narrow, so our values are precise around the estimate too.
Yes, and here we use odds ratios and then adjusted odds ratios for gender, which show that the clinical significance for our study, as discussed in the slides prior.
So finally, we're going to look at external validity. So will the results help me care for my patients? So are my patients similar enough to those in the study? For the quick wee, again, sort of. Our patients here present with similar symptoms. They present with fevers of unknown origin. They're fussy. They're coming with poor feeding, vomiting.
And with the bladder stim, our patients range from 1 day to 24 months, but the procedure seemed to be more suited for those under the age of 1 in under 10 kilograms. We don't know how similar they are because the demographics were not clearly reported, but on the good hand, it was controlled for UTI and gender.
Is the treatment feasible in my setting? So if we're looking at quickly versus the bladder stim, the quickly only requires one person, so one person's doing this, both holding the cup and doing the circular motion, versus the bladder stim, like one person's holding and tapping and so
Staying alive.
singing. So there's that one takes 3 individuals, but then comparing to CAS, so that one also takes multiple people to hold and to do the CAS, but depending on who's doing the CAS, it can be a lot faster as well. All right. So will the potential benefits of treatment outweigh the potential harms of treatment for my patient? Again, maybe. So it's not as invasive, so the benefits of comfort. They also looking at, even though potential bias, but quickly the patient satisfaction score of 2, which is satisfied, and then it's also cheaper. And then looking at complications, possible complications of urine cath, we don't really think about it because we do it so often, but urethral injury. But the potential harm is possible higher rate of contamination of the clean catch, although they only used normal saline to clean the general area, and we don't do that here. It's very nice. So our conclusions. Both tests demonstrate with little effort and proper training of staff that probably it's worth taking a few extra minutes to try to collect a urine sample using these non-invasive techniques. It's quickly better than bladder stim, considering that only one person doing it versus 3, and it was a randomized control trial, so it's a higher study on the hierarchy. But we definitely need more studies looking at different aspects. For example, comparing urine cath and the different bladder stimulation techniques, and also looking at the contamination rate of the various bladder stim techniques. Considering looking back at the high contamination rate, even though it wasn't significant, and there was a bias there too. So those were our conclusions. This is oh, sorry. I didn't change it, but...
She's trying to say, this is my slide. So should we try it in our office in clinical practice or in emergency department? Okay. The answer is that's it in French. So I've done this procedure in our clinical continuity clinics with Dr. Bekhani and showed her and what's successful. I've done it multiple times in the emergency department here. And also successful, and everyone kind of enjoyed the opportunity to try it. And the times that I've done this, and my success rate has been quite high, probably around 80%. And the 2 times that I've failed were kind of very similar to the study that we've done. They were a little bit older, they were a little bit bigger.
Have you tried both of them?
I've only done the bladder stimulation technique with Characteristics. Huh?
What was your end? How many patients?
Probably about 10. I've done.
Wow.
You need a higher end.
Yeah. So does anybody have any questions from the audience for Pete to do? Yep. Okay.
Do I look like I have questions?
So thank you very much for coming to today's journal club. I enjoyed speaking to you today, and look forward to everyone having a very Merry Christmas and a Happy New Year and Hanukkah and all the other celebrations.